Usually when you place an implanted medical device, it's supposed to be completely inert.
Right, yeah.
You place it, the body builds this quiet, predictable wall of scar tissue around it, and it just stays there. But what happens when that sterile pocket transforms, like over a decade, into a slow-cooking petri dish of malignancy?
It's a terrifying thought,
Oh,
obviously.
yeah, it really is. Today, we are talking about breast implant-associated anaplastic large cell lymphoma, or BIA-ALCL. And if you are a resident staring down your board exams, you need to know this inside and out.
Absolutely. It comes up all the time now.
First, head to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck with over 7,000 questions arranged by topic to turn revision into active recall. Based on the textbook Keynotes in Plastic Surgery, it is the go-to companion exam question guide.
It's a lifesaver for boards, really.
This is a free Journal Club episode. Become a member of our podcast to access all our Journal Club episodes and clinical cases. All right, our mission today is to equip you with a fast, high-yield question and explanation breakdown of the presentation, diagnostic algorithm, and surgical management of BIA-ALCL.
So we're getting right into the weeds.
Exactly. Let's get right into the clinical reality of this disease, because to treat it, we have to know exactly what it is on a cellular level, right? So what exactly is this malignancy?
Well, BIA-ALCL is it's an uncommon T-cell non-Hodgkin lymphoma, and it arises specifically in association with breast implants.
Okay. Does it matter why the implant was placed? Like cosmetic versus reconstructive?
No, not at all. Regardless of whether that implant was placed for cosmetic augmentation or, post-mastectomy reconstruction, the reason doesn't matter. The physical presence of the implant does.
Got it.
And for the exams, the critical signature you're looking for on any pathology report is its specific immunohistochemical profile. It is characteristically anaplastic lymphoma kinase negative.
So ALK negative.
All right, ALK negative.
Right.
And strongly positive for CD30.
ALK negative and CD30 positive. Let's just pause there for a second, because it's super easy to just memorize those acronyms without actually understanding the biology.
Oh, for sure.
Because CD30 is a cell membrane protein, right? It's part of the tumor necrosis factor receptor family.
Exactly.
And in a normal immune system, it's expressed on activated T and B cells to help regulate the immune response. But here, the cells are strongly positive for it. So, they're overexpressing it in this malignant, completely uncontrolled way.
Yeah, that overexpression is the defining feature. And the ALK negative status, that's equally important to understand.
Why is that?
Because in systemic anaplastic large cell lymphoma, the kind not associated with implants, you can have ALK positive or ALK negative variants. And typically, the ALK negative ones have a much poorer prognosis.
Oh, wait, really?
Yeah. But BIA-ALCL, despite being ALK negative, behaves completely differently. When it's caught early, like when it's just confined to the implant capsule, it actually has an incredibly favorable prognosis.
Okay, that's a huge distinction for the exams. So I'm imagining a patient sitting in clinic. She's, say, 8 or 10 years post-op, and suddenly her breast is significantly swollen and asymmetrical.
Right.
My initial resident instinct jumps to, I don't know, a late-stage infection, or maybe a delayed hematoma. What is the specific red flag that should make me stop and think, wait, this could be lymphoma?
The absolute hallmark presentation is a late seroma.
Late meaning what timeline exactly?
By definition, we are talking about a peri-implant fluid collection occurring more than 1 year post-implantation.
Okay, more than 1 year.
Yeah, though the median time to presentation is actually like 8 to 10 years. Now, it's important to note that about 90% of chronic delayed seromas are just clear or hemoserous fluid.
Right, from mechanical shear or something?
Exactly, or a subclinical infection. And they aren't associated with malignancy at all. But you have to prove that. You can't just assume.
So fluid is the main thing. Does it ever present as a solid tumor?
It does, yeah. Less commonly, instead of a massive fluid collection, the patient will present with a distinct solid tissue mass. And that usually forms on the inner aspect of the capsule itself.
Okay, so late seroma or a capsular mass. Now we have to address causality, because I know not all implants carry this exact same risk.
Yeah, they definitely don't.
And this is where the history of breast implants gets a bit ironic, honestly, because textured implants were specifically designed and popularized to prevent capsular contracture, right?
Right, the rough surface was meant to disrupt those planar vectors of scar tissue formation.
Yeah, but that very texture is what's on trial here.
Precisely. The higher rates of BIA-ALCL are heavily associated with macro-textured surfaces. They have a significantly higher surface area and roughness compared to smooth implants.
And what about purely smooth implants?
To date, there have been absolutely zero confirmed cases of BIA-ALCL in patients with a breast implant history that strictly involves purely smooth devices.
Zero. Wow.
Zero. The textured surface is strictly implicated in the pathogenesis.
Wait, let's look closer at that mechanism then. Because if I think about a textured implant, I think about physical friction. It's rough, it rubs against the surrounding tissue.
It acts like Velcro, essentially.
Right. But if this is just basic mechanical inflammation, why are we seeing highly specific malignant genetic mutations? Like the JEXSTAT pathway alterations, rather than just a standard reactive immune response? I mean, a callus is a response to friction, not a lymphoma.
That's a great point. It's really the perfect storm of a newly created microenvironment. It is not just simple mechanical rubbing.
So what else is in that Petri dish?
The pathogenesis involves a really complex combination of chronic triggers trapped within that capsule. So you have the repetitive trauma and friction, yes, but those microscopic valleys on the textured surface?
The actual texture itself.
Right. They provide a perfect scaffold for bacterial biofilm formation.
Yeah.
Specifically organisms like Ralstonia species.
Oh, interesting. So there's a chronic, low-grade bacterial presence.
Exactly. Add to that the potential for microparticulates actually shedding from the implant shell over a decade. All of this creates an intense, highly localized, and just relentless chronic inflammatory response.
Okay, so the immune system is constantly sending T cells into this enclosed space to fight an enemy it can never clear. It just keeps trying and trying.
And feeling, yeah. And over a period of 8 to 10 years, that localized chronic inflammation forces specific genetic and epigenetic modifications in those local T cells.
And that's where the JAK-STAT mutations come in.
Exactly. The most frequently reported mutations involve the JAK-STAT signaling pathway, specifically genes like JK1 and STAT3, as well as epigenetic modifiers like DNMP3A.
And normally those pathways are what control cell proliferation and survival.
Right. So when they mutate due to this chronic stress, the T cells basically refuse to undergo apoptosis. They refuse to die.
Yeah.
They adopt this aberrant phenotype and just begin cloning themselves, slowly filling up that effusion.
Okay, so the chronic inflammation is the engine, but the JAK-STAT mutation is the mechanism that actually turns it into cancer.
That's a great way to put it, yeah.
All right, so we have a patient with a late seroma, and they have a textured implant in their history. The clinical suspicion is high. How do we definitively prove this diagnosis without messing up the pathology sample? Let's start with imaging.
So ultrasound is your initial investigation of choice. Always.
Why ultrasound specifically?
It is highly accessible, it's cost-effective, and it's incredibly sensitive, like over 80% for detecting peri-implant fluid collections.
Gotcha.
And when performing the ultrasound, the operator shouldn't just look for fluid. They need to assess the capsule for any solid masses, which can be ovoid or mixed cystic solid. And they also need to carefully evaluate the regional axillary lymph nodes.
See, I would assume an MRI would give us much better anatomical details straight out of the gate. Why hold off on the heavy imaging initially?
Because MRI can sometimes really muddy the waters early on, especially with severe inflammation that might mimic a mass, or it might give you false positive enhancement.
Oh, I see. So you might end up overcalling it.
Exactly. MRI is reserved for cases of diagnostic uncertainty, or you use it to assess the true extent of the disease and aid surgical planning only after the diagnosis is cytologically confirmed.
Okay, that makes sense. So once we have the cytology, then we put them in the scanner.
Right. Once confirmed, non-contrast sequences and silicone-selective imaging can rule out implant rupture, while dynamic contrast-enhanced sequences are used to hunt for subtle capsular enhancement or, masses that the ultrasound might have missed.
So the ultrasound confirms a massive peri-implant effusion. Let's talk about the golden rule of BIA-ALCL diagnosis, which really comes down to the fluid aspiration.
Yes. The aspiration is critical.
If there is an effusion, fine needle aspiration is absolutely required. But hold on. The guidelines state we need to send the entire volume of the seroma.
The entire volume, yes.
Listen, in a busy clinic, draining 500 cc's of fluid and sending a literal half-liter bucket to pathology sounds absurd. Standard protocol for any fluid sample, like a joint tap or an abscess, is just a 10 cc universal container. Why can't the lab just work with 10 cc?
because treating this like a standard infection sample is a guaranteed way to miss the diagnosis entirely.
Really? Just from the volume?
Yes, the neoplastic cells in BIA-ALCL are incredibly sparse. They don't form this thick, visible sludge. They are microscopic and they float in a massive sea of standard inflammatory cells, debris, and fluid.
Oh, okay. So it's basically a needle in a haystack.
Exactly. Small volume aspirations are highly associated with false negative cytology.
So we need a better way to visualize this than just hoping a few cancer cells happen to swim into our little 10 cc syringe.
Right. Think of the laboratory process like panning for gold in a fast-moving river. You wouldn't scoop up 1 cup of water and declare the river completely empty if you didn't find a gold nugget, right?
Right, you process a ton of dirt and water.
Exactly. You need to dredge large volumes of material and spin it down. So the cytology department takes that entire 500 cc volume and puts it through a centrifuge.
And that concentrates the cells.
Right. They spin it down at high speeds to force all the heavy cellular material to the bottom. This creates a concentrated button of cells to make cytospins and cytoblocks.
And if you only send 10 cc.
That button is practically non-existent. There's nothing to test. You must drain the entire effusion volume. Ideally, a minimum of 50 milliliters, but if there's 500 cc in there, you take the full 500 cc.
And how should that vast amount of fluid actually be packaged for the lab? Like, I'm just picturing a massive jug.
Well, you split the sample. You send some in purple top EDTA tubes for the Hematological Malignancy Diagnostic Service. You send a portion for microbiology to rule out standard bacterial infection.
Right.
And then the cytology department receives the remaining bulk volume in multiple sterile containers.
Yeah.
And you must explicitly state your clinical concern for BIA-ALCL on the request form so they know to actually perform the specific stains required.
Okay, so the cytology department spins it down. Their primary assessment is morphological, right? They're looking for pleomorphic lymphocytes with those hallmark horseshoe-shaped nuclei.
Yes, the hallmark cells.
But morphology isn't enough to make a definitive diagnosis, which is why they moved to secondary assessment using immunohistochemistry and flow cytometry.
Exactly. They use markers to confirm the hematopoietic origin of the cells. So they look for T-cell markers like CD2, CD3, CD4, CD5, CD7, and CD8.
Lots of CDs.
Yeah, and crucially, as we discussed earlier, they must confirm the cells are strongly positive for CD30 and strictly negative for ALK.
Okay, but the guidelines also mandate checking B-cell markers like CD20, CD79A, and PAX5.
They do, yes.
If we already strongly suspect a T-cell lymphoma, why spend lab resources checking B-cell lines?
Because of the very specific differential diagnosis.
Yeah.
Fibrin-associated diffuse large B-cell lymphoma, or DLBCL.
Okay, what is that?
It's another rare lymphoma that can sometimes develop in the setting of chronic hematomas or pseudocysts, and that includes around breast implants.
Oh, wow, so it mimics BIA-ALCL.
It can, yeah. DLBCL can occasionally display aberrant expression of CD30 and other T-cell markers. Furthermore, CD30 expression alone does not define BIA-ALCL. I mean, it's present on normal activated T, B, and natural killer cells anyway.
So you really have to cast a wide net with the markers to be absolutely sure.
Right. You need the full panel to prove it's a T-cell lineage, exclude a B-cell lineage entirely, and confirm that specific CD30 positive ALK negative profile.
All right, so the pathology comes back. We have a confirmed BIA-ALCL diagnosis from the fluid. Now we're moving from the clinic to the operating theater. What is the definitive surgical approach here?
The recommended primary treatment for all patients, provided they do not have advanced systemic disease, is total en bloc capsulectomy and implant explantation.
Total en bloc.
Yes, this is curative for the vast majority of patients with early-stage disease confined to the effusion or just the inner lining of the capsule.
I look at this en bloc procedure as being equivalent to, like, removing a hazardous waste containment bag.
That's a perfect analogy.
When you extract a biohazard, the absolute last thing you want to do is nick the bag with a scalpel and spill the contents all over the surgical field. One leak contaminates the entire site. Technically, achieving this is incredibly delicate.
Extremely delicate. The objective is to remove the entire intact, unbreached capsule, the implant inside it, and the associated malignant effusion as one complete contiguous piece.
So you're not popping it to drain the fluid first?
No, absolutely not. This is entirely different from the piecemeal or partial capsulectomy approach you might use for a standard capsular contracture, where you just want to release tension.
What happens if it pops? Like if you inadvertently breach a thin capsule?
If the effusion fluid contaminates the operative field, the cavity must be exhaustively irrigated before wound closure. Local recurrence has been directly linked to the seeding of effusion fluid from drain exit sites.
Wow. And depending on the implant plane, dissecting that intact capsule can be perilous. I mean, if the implant is subpectoral, the posterior capsule is often densely adherent to the rib periosteum and the intercostal muscles.
It's stuck right to the chest wall.
Right, so attempting a total en bloc resection there carries a recognized risk of pneumothorax. It's been reported up to 4% in some series. You are literally peeling a malignant balloon off the chest wall.
Which is why meticulous surgical technique is paramount.
Yeah.
And once that specimen is successfully out, the handling of the tissue is just as critical. The pathologists need to map the capsule to determine if the tumor has invaded through it.
So you must formally orientate the capsule using specific external sutures.
Yes, you have to label it for them.
The standard convention for breast pathology orientation: short superior, long lateral, medium medial, and a double loop anterior.
Exactly.
Let's explain why this mapping actually matters. Because the pathology lab is a chaotic environment. They receive this amorphous, slippery blob of tissue.
Right, it just looks like a deflated balloon to them.
Yeah. And if they find microscopic tumor deposits penetrating the capsule, the surgeon needs to know exactly where that breach occurred on the chest wall. If the breach is at the short superior margin, the surgeon knows exactly where to direct adjuvant radiation. Without those orientation sutures, that critical geographic data is just lost.
It dictates the entire postoperative management plan. You cannot skip the sutures.
Now, here is a clinical dilemma. Say we are in the OR performing the en bloc resection. Prior to prepping the patient, our clinical exam noted palpably enlarged axillary lymph nodes.
Okay.
The instinct for any breast surgeon seeing swollen nodes during a malignancy case is to perform a sentinel lymph node biopsy.
Naturally.
So should we do it here?
No, you should not.
I don't know.
There is zero role for sentinel node biopsy in BIA-ALCL. The pathophysiology is completely different from standard breast carcinoma.
Okay, but what are those swollen nodes then, if not cancer?
If you see enlarged axillary lymph nodes clinically or on a staging PE scan, you cannot assume they are lymphomatous. They are very often just demonstrating reactive hyperplasia due to the intense regional inflammation caused by the implant and lymphoma sitting in the capsule.
Ah, so they're just angry nodes, not malignant nodes.
Exactly. You only excised clinically enlarged abnormal nodes for direct histological confirmation. Routine sentinel node biopsy will not change your management and is strongly advised against.
Got it. Let's talk about staging once the pathology report returns. Are we using the traditional Lugano or Ann Arbor staging systems that oncologists use for other lymphomas?
No, traditional lymphoma staging systems do not reflect the biology of BIA-ALCL well at all.
Why not?
Because this disease originates in a unique, newly created anatomical space, the synthetic organ of the implant capsule itself. So the American Joint Committee on Cancer created a specific T&M staging system based heavily on tumor penetration through that capsular barrier.
Walk us through the T stages of the specific system.
Okay, so T1 means the lymphoma cells are confined strictly to the effusion, or they're just resting on the luminal inner side of the capsule.
So completely contained.
Yes. T2 indicates superficial infiltration into the luminal side. T3 means the cell aggregates have penetrated deeply into the capsule tissue itself.
Getting close to the edge.
Right. And T4 means the cells have infiltrated entirely beyond the capsule wall into the surrounding native breast tissue or the chest wall.
And how do the early stages do?
Patients with disease limited to the effusion or the capsule stages 1 and 2A have a fantastic prognosis. Up to 93% achieve complete remission solely with the en bloc capsulectomy.
But what happens when that hazardous waste bag is truly breached? Total capsulectomy cures the early stages, but what is the protocol for advanced cases where the disease forms a distinct mass beyond the capsule or it actively spreads to the lymph nodes?
Once the disease extends beyond the capsule, we are dealing with a much more aggressive clinical entity. The very first step before any surgical intervention is a comprehensive, multidisciplinary team discussion.
You need the medical oncologists involved.
Absolutely. And you must attain a baseline FDG PTCT to accurately stage both local and distant disease.
And what are the systemic treatment options for those advanced stage 2 to 4 cases?
Systemic chemotherapy is typically required upfront. The standard first-line regimen is CHOP, cyclophosphamide, doxorubicin, vincristine, and prednisolone.
Okay, standard CHOP.
Yes. And interestingly, while ALK-negative systemic ALCL usually has very poor outcomes with CHOP, BIA-ALCL behaves favorably and generally responds very well to this regimen.
That is fascinating. And if the disease relapses or proves refractory to CHOP?
Then we use targeted therapies. Brentuximab vedotin is an anti-CD30 antibody drug conjugate.
Oh, because the cells are CD30 positive?
Exactly. Think of it like a Trojan horse. Because we established early on that BIA-ALCL is strongly CD30 positive, this drug just circulates harmlessly until it encounters a cell displaying that specific CD30 lock.
And then it binds.
It binds to the receptor, the cell internalizes it, and only then does it release its toxic payload to destroy the cell from the inside. It has shown excellent results in relapsed or refractory cases, offering long-term remission.
What about radiotherapy? Because as reconstructive surgeons, we deal with adjuvant radiation for breast cancer constantly. What is its role in this lymphoma?
Adjuvant chest wall radiotherapy is not routinely recommended after total capsulectomy for early-stage disease. However,
There's always an exception.
it is strongly considered if there are histologically confirmed positive surgical margins in T1 or T2 tumors, and further surgical excision simply isn't anatomically possible.
Like if it's stuck on the ribs.
Right. For instance, if the tumor is invading the intercostal space, the optimal dose typically aligns with protocols for other high-grade lymphomas, ranging around 24 to 36 gray.
Okay, before we wrap, we need to touch on the administrative and regulatory side of this disease. Because this involves a manufactured medical device, the oversight is heavily scrutinized. What is the surgeon's duty once this diagnosis is confirmed?
The operating surgeon has a strict regulatory and legal duty here. Every single confirmed case must be reported to the National Regulatory Authority.
So in the UK, that would be the MHRA.
Right. In the UK, that is the MHRA via the Yellow Card scheme, and the case must be recorded in the Breast and Cosmetic Implant Registry.
And what happens to the implant itself?
The explanted device cannot be thrown away in standard biohazard waste. And you certainly cannot let the patient take the implant home as a morbid souvenir.
Yeah, please don't do that.
It must be treated as a biohazard, securely packaged, and returned to the manufacturer.
Why the manufacturer?
The manufacturer is legally obligated to collect the implant, perform rigorous analysis on the shell and the biofilm, and provide their findings in a formal vigilance report to the authorities. They are on the hook to investigate.
Got it. Okay, let's run through a rapid-fire recap of the key clinical realities we've covered today. For the presentation, look for a late seroma occurring more than 1 year, typically 8 to 10 years, post-implantation around a textured implant. The diagnostic algorithm. Start with an ultrasound, and if you see fluid, you must aspirate the maximum possible volume to allow the lab to centrifuge it. Never descend 10 cc.
Never.
Pathology. You are hunting for CD30 positive, ALK negative T cells. And finally, treatment. The definitive curative approach for early disease is a total en-bloc capsulectomy without spilling the contents, with absolutely no role for sentinel lymph node biopsy.
You know, if we pull all this back to the underlying biology, it raises a fascinating question about the future of our specialty.
How so?
Well, we discussed how BIA-ALCL is fundamentally linked to specific genetic mutations like GAK1 and STAT3, which are triggered by the chronic inflammation of the textured surface.
Right.
As our understanding of this pathogenesis deepens, could the future of plastic surgery involve routine genetic screening of patients before we ever offer them breast implants? If we could identify patients genetically predisposed to these hyperreactive, malignant pathways, we could effectively prevent this lymphoma from ever developing.
Imagine eliminating the petri dish entirely by knowing who is genetically susceptible to the reaction before we even make the incision. I want to pass that question over to you listening. What do you think about the feasibility of routine genetic screening prior to breast implantation? Drop your thoughts on this idea or any questions you have about the diagnostic algorithm or the surgical nuances in the comments section below. Our job isn't just to manage the complications, it's to deeply understand the physiological environment we are creating when we place an implant. Good luck with your exam revision and keep diving deep.